السلام عليكم يا دكاترة. إن شاء الله هنتكلم في السكشن دوت عن sinusitis. Sinusitis means an inflammation of the sinuses. So what are the sinuses? Sinuses are air-filled spaces. Normally we have four pairs of paranasal sinuses. These are the frontal sinus in the front of your head, the maxillary sinus behind your cheeks, the ethmoid and sigmoid sinuses. Normally, these sinuses, as we said, are filled with air and they are lined with a thin layer of mucus that trap dust and foreign organisms. Normally, the mucus drains and fall out of the nose. In case of sinusitis or sinus inflammation, the inflammation will result in obstruction of the sinonasal drainage pathways and result in buildup of mucus inside the sinus with the subsequent increased risk of infection. Sinusitis can be classified based on the onset and the duration of symptoms into acute sinusitis. If the with sudden onset of symptoms that usually persist for less than a month or less than 4 weeks. If the symptoms lasted for 4 up to 12 weeks is called subacute sinusitis, while individuals experiencing symptoms lasting for more than 3 months are said to have chronic sinusitis. Some individuals experience repeated episodes of acute sinusitis and they are said to have recurrent sinusitis if they experienced at least 4 separate episodes of acute sinusitis per week. Some individuals are more prone than others to develop acute sinusitis. If they have nasal polyps, these are benign growths inside the nose that obstruct the sinonasal drainage pathways and result in increased risk of sinusitis. For individuals with nasal septal defect, as nasal septum normally separates the nose into 2 equal nostrils. Some individuals, they have an important nasal septum defect with one nostril being narrower than the other. They are more prone, therefore, to develop sinusitis. Allergic diseases, this is particularly important for people with chronic sinusitis, where exposure to allergen will triggers an inflammatory reaction and result in inflammation of the sinus or sinusitis, as those with asthma, allergic rhinitis, or even حتى those with food allergy. Individuals with immune deficiency and those with AIDS, diabetes, patients on immune suppressant medications as chemotherapy or corticosteroids, or individuals with inborn immune deficiency disorders, all of them are more prone to infection and more prone to develop sinusitis than others. Smokers are more prone also to develop sinusitis compared to non-smokers. We will focus mainly on acute sinusitis. So what causes an acute sinusitis? Acute sinusitis can be classified based on the cause into either infectious or non-infectious sinusitis. Non-infectious sinusitis most commonly related to allergies, where the exposure to allergen trigger an inflammatory reaction causing sinusitis. يعني غالبا كده مثلا الناس في الربيع بيجي يقول ان الجيوب الانفيه دي مبهدلاهم. طب بيبقى ايه المشكله؟ الناس دول بيبقى عندهم allergies to pollens، فالاكسبوجر في الحاله دي ساعه الربيع للبولنز trigger the inflammatory reaction and causing them to have sinusitis. لكن المajority of cases بتاعت الacute sinusitis هتبقى caused mainly by infectious causes, with viral infection being the leading cause, accounting for about 90% of cases of infectious sinusitis. غالبا a patient experience acute sinusitis following an episode of a common cold. عشان كده دايما لو حد عنده برد بنقول له ان هو لازم يعالج البرد بتاعه كويس والا otherwise هي ممكن تقلب معاه sinusitis. أو ممكن تكون infection caused by bacterial infection by the same bacteria that are causing upper respiratory tract infection, including Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis. حاجة مهمة، لو كانت الانفكشن لو كان الساينوسايتس caused by a viral infection فبتيجي تعمل symptoms في خلال 3 ل 4 أيام وبعدين then the symptoms lessens gradually and completely disappear within 10 days. على عكس بقى لو كانت الانفكشن of bacterial origin ففي الحالة ديت ال symptoms tend to persist longer and tend to even tend to be worse than that caused by a viral infection. In very rare circumstances, an acute sinusitis can be caused by fungal infection. Symptoms of acute sinusitis. Patients with acute sinusitis will have purulent nasal discharge, nasal congestion or softness, facial pain or pressure, These are the three cardinal symptoms of acute sinusitis, and they are necessary for a diagnosis of acute sinusitis. Other symptoms include cough, fatigue, decreased sense of smell, fever, bad breath or halitosis, and headache. Looking at the symptoms itself, the symptoms do not distinguish a bacterial from viral infection. Some can say that the purulent nasal discharge distinguishes bacterial from viral infection and is more commonly associated with a bacterial infection. However, this is not totally true. Discolored or purulent nasal discharge can be seen in both bacterial and viral infection, and the discoloration of mucus here is attributed to the presence of large number of neutrophils rather than the presence of bacteria. So how we will distinguish a bacterial from viral infection, and this is quite important as it will affect the treatment decision. As we said, viral infection usually peaks within 3 to 4 days and then subsides and disappears completely within 10 days. So if the symptoms persisted without any evidence of improvement for at least 10 days, or if the symptoms improved initially but get worse again within 10 days, it's called a bacterial infection. Another way to distinguish a bacterial from viral infection is to obtain a sample of the mucus in the paranasal sinuses and then make a culture. If the culture test result is positive, then this suggests a bacterial infection. If it's negative, this suggests a viral infection. However, to obtain a mucus sample from the paranasal sinuses, this is quite difficult and have to be guided by an endoscope. So this is not performed in routine clinical practice. The diagnosis of acute sinusitis depends on the clinical presentation. As we mentioned before, the presence of the three cardinal symptoms of acute sinusitis, including purulent nasal discharge, nasal congestion, and facial pain or pressure. Physical examination, where the physician taps and presses the sinuses to check for tenderness and inflammation. Also, he may look into the nose using a lighted instrument. This is usually sufficient to diagnose an episode of acute sinusitis. Other tests may be required, including mucus culture, CT scan, MRI, and nasal endoscopy. They are required only in certain circumstances and not performed in routine clinical practice. So how to treat an episode of acute sinusitis? Symptomatic treatment will be the key. First of all, the patient has facial pain and headache, so we have to prescribe an analgesic, including either use a paracetamol or non-steroidal anti-inflammatory drugs. Paracetamol is used at a dose of 325 mg up to 1 gram oral every 4 to 6 hours when required when there is a pain, with a maximum daily dose of 4 gram daily. Or ibuprofen at a dose of 200 or 400 mg oral every 4 to 6 hours, with a maximum daily dose of 3,200 mg daily. To relieve nasal congestion, we can apply or perform a nasal saline irrigation. Nasal saline irrigation actually have many benefits. It improves mucus clearance, enhances bacillary activity, and allow removal of antigens, biofilms, and inflammatory mediators. Also provide a direct protection of the sinonasal mucosa. Let's look together how nasal saline irrigation works and how can we perform it.
It is important to review the relevant nasal and sinus anatomical structures to enable you to understand how this.
Well, if you look, we find that the sinuses on the right and on the right side and on the left side of your face are connected at the back of your head. So if fluid is sprayed into one nostril, it will flows and it will move and flows back from the another nostril.
This device works. The nasal cavities on each side are connected towards the back of the head. This means that fluid inserted under gentle pressure into one nostril will flow through the nostril and nasal cavity on that side, and then around the back and down and out through the opposite nostril. There is a flap of tissue towards the back of the mouth called the soft palate. When you breathe through the mouth, this flap of tissue is raised and closes off the nasal cavity from the oral cavity. This ensures that fluid in the nasal cavity does not enter the back of the throat and cause you to gag or have a choking feeling. If you do not breathe through the mouth, then fluid can easily enter the back of the throat. Using the device. With your head bent forwards so that your chin touches your chest, either over a basin or in the shower. Insert the tip of the cap into one nostril so that it gently seals the nostril. Next, gently squeeze the bottle to start the flow-in liquid. Squeeze continuously until about half of the bottle has been emptied. You will see the irrigation liquid flowing quite steadily out of the opposite nostril. If you need to stop the procedure for any reason, withdraw the bottle from your nostril before releasing pressure on the bottle. This will prevent it from sucking back fluid into the bottle. You can then restart your treatment. So, to remove excess.
Also, to relieve nasal congestion, we can use a decongestant, either topical or nasal decongestants. However, they should not be used continuously for more than 3 to 4 days. Otherwise, they will result in worsening of congestion or a condition called rebound congestion or rhinitis medicamentosa. Oral decongestants can be used also as pseudoephedrine, provided that there is no contraindication of hypertension or peripheral vascular disease. Antihistaminics plays a key role, particularly if the sinusitis is associated with allergy. In this case, we will prefer a second generation agent as loratadine or cetirizine over first generation, as they cause less sedation and are associated with less anticholinergic side effects. Topical or nasal corticosteroids can be also used. They help to relieve sinonasal inflammation and reduce the symptoms of sinusitis. They have no or minimal systemic absorption, and therefore they cause no or minimal systemic side effects, just causing nasal itching or nasal irritation and nosebleeds in some cases. Topical steroids include beclomethasone, triamcinolone, and budesonide. So what about antibiotics? As we mentioned before, about 90% of cases of acute sinusitis are caused by a viral infection, and therefore they will not benefit from an antibiotic. Antibiotic is recommended only when there is an evidence for acute bacterial sinusitis. For individuals with an acute bacterial sinusitis, we have two options: either wait and see approach or begin the antibiotic immediately. The wait and see approach depends on that most infections are self-limited and will resolve on their own. So we give the patient a chance for 7 days. If the symptoms improve, there will be no need for an antibiotic. If the symptoms persist or get worse, then we have to start an antibiotic. Or we can start antibiotic immediately from the beginning. Amoxicillin with or without clavulanic in this case will be the first choice. In case of penicillin allergy, doxycycline or respiratory quinolone, as moxifloxacin or levofloxacin represent a good choice. The choice of either wait and see approach or beginning the therapy with antibiotic immediately depend on the patient preference. So we have to make the decision based on appropriate discussion with the patient about the benefit of each choice. If you use amoxicillin, the amoxicillin will be used at a dose of 250 mg orally 3 times daily to 500 mg twice daily, and the duration of treatment will be from 5 to 10 days. Based on the severity of infection, with more severe infections require longer courses of treatment. If we use a wait and see approach, this requires the patient to come back after 7 days to the physician to look if his symptoms have improved or not. This will not be always accessible, and some patients will not have the chance to make a second visit to a physician office. So one solution is the use of a wait and see antibiotic prescription, where the physician write down the prescription of antibiotic but inform the patient that he only should fill the prescription if there is no improvement of the symptoms after 7 days, or if the symptoms get worse at any time. If the patient filled the prescription, he should inform the physician back that he filled the prescription with an antibiotic. Let's look together into the cases. Cases are on page 35 in your practical book. A 38-year-old female who visited her physician, and she suffers from sudden onset facial pressure and pain over her left cheeks, nasal stuffness, loss of smell, fever, bad breath, dental pain, and thick yellow color sinus drainage over the previous 8 days. The physician starts a physical examination. He starts feels and presses her sinuses that reveal the tenderness. He taps her teeth that reveal inflamed paranasal sinuses. The woman was promptly referred to the ENT service. A mucus culture in the stain showed gram-negative organisms, most likely Morbus influenza. A CT scan showed air and the fluid in the left maxillary and left frontal sinus. ELISA blood food allergy testing showed a high reactivity to eggs and dairy products. Her post-medical history included prednisone, 5 mg 3 times daily for hair psoriasis over the past month. What is the exact diagnosis of this woman's condition? This woman is said to have an acute bacterial sinusitis. So what are the subjective and objective data confirming this diagnosis? First of all, subjective data, let's look at the patient's symptoms. She came reporting symptoms of facial pressure and pain, nasal stuffness, thick yellow color sinus drainage, loss of smell, fever, and bad breath. The symptoms started 8 days ago. Also, her past medical history indicates the use of methylprednisolone in the past months, which is an immunosuppressant medication that may result in an increased risk of infection and increased risk of sinusitis. The objective data included physical examination revealed the tender and inflamed paranasal sinus, with mucus culture confirming the presence of an acute bacterial infection with gram-negative organism, most likely Haemophilus influenza. With CT scan showing fluid in the left maxillary and left frontal sinus, and ELISA blood food allergy testing revealed a high reactivity to egg and dairy products, suggesting that the presence of an allergy is a risk factor of sinusitis. So what are the risk factors for this woman's condition? We have 2 risk factors: food allergy and the use of immunosuppressant medication, corticosteroids, and methylprednisolone. How this woman's condition could be treated? First of all, she should avoid the allergy, including eggs and dairy products. She has pain, so we have to recommend her to use an analgesic, paracetamol or ibuprofen with the doses said before. Also perform nasal saline irrigation to relieve nasal congestion and stuffness. If needed, we can then use a decongestant. Also, we can add topical steroids if required. The use of antibiotic should be considered after discussing with the patient, either to wait for 7 days. If the symptoms get improved, there is no need for an antibiotic, or we can start antibiotic immediately. If antibiotic to be prescribed, then we have to prescribe amoxicillin at a dose of 250 mg 3 times daily, 500 mg or 500 mg twice daily, and consider shorter courses of 5 days because the patient has only mild symptoms. Jessica, a 26-year-old student, presents to you complaining of a 4-day history of colored nasal discharge, headache, lethargy, and sneezing. She's taking regular paracetamol for headache but has not tried anything else. She's a non-smoker with no significant medical history or drug allergies and doesn't take any other regular medicines. Her exams start in 2 weeks, and she feels a course of antibiotic will help her recover more quickly. Jessica appeared tired, shivery, and is constantly blowing her nose. On examination, she has a temperature of 37.8 degrees centigrade but no other signs or symptoms. Looking at her temperature, she is aphid-colored. So what symptomatic management would you advise for Jessica? Non-pharmacological treatment, including nasal saline irrigation to relieve nasal congestion and the application of warm compresses to the affected sinuses to relieve pain is recommended. The use of alternative analgesic as paracetamol did not work for this patient, so we have to replace it with ibuprofen. The use of decongestants to relieve nasal congestion seems rational. Also, if we needed, we can then add a nasal corticosteroid. Would you recommend an antibiotic at this stage? No, antibiotic in this case will not be recommended. So what reasons would you give to Jessica for not recommending an antibiotic? Well, she has an infection that started at least, or the symptoms started 4 days ago. So we can say it's a bacterial infection, and 90% of cases are caused by viral infection. So it's likely that she has a viral infection which will not benefit from an antibiotic. And just the use of antibiotic will add to the side effects ولقيت side effects to the patient without any underlying benefits. Bacterial infection is suspected only if the symptoms persisted without any improvement for at least 10 days. Jessica returns 4 days later, complaining that her symptoms and tired nasal discharge have got worse. She also has unilateral facial pain and tenderness, and a temperature of 38.5 degrees centigrade. She developed fever. How would you manage Jessica illness now? Would you continue the current antibiotic, change the current antibiotic, or start an antibiotic, or would not recommend an antibiotic? The condition, the condition here has started 8 days ago. It's getting worse and not improving. It's likely that it will be caused by a bacterial infection. But until, so if we wait for 2 days, another 2 days, wait for 2 days before prescribing an antibiotic. So now we will not recommend an antibiotic. Wait for another 2 days before prescribing an antibiotic. Would you refer Jessica for medical imaging? Medical imaging, a CT scan or MRI, are quite expensive. Also, we expose the patient to a dose of radiation, so that patients with sinusitis are not routinely instructed to perform medical imaging unless there is a suspected complication, including the spread of infection to other parts of the head, causing orbital cellulitis with the swelling of the eye, or meningitis indicated by symptoms like neck stiffness. Patient doesn't have any of these symptoms or any indicator of a complication. Or if there is an alternative diagnosis as a tumor is suspected, then we will recommend an imaging. In this case, we will not recommend an imaging. There is nothing that indicates it can have a tumor. So it's not recommended at all at this stage. Thanks a lot for listening.